The title of this lecture is The Expanding Spectrum of Primary Aldosteronism, wherein I will discuss some of the new ways primary aldosteronism is being viewed and how that is influencing clinical practice. My goals for this lecture are to help redefine primary aldosteronism from a categorical or binary condition to a syndrome that manifests across a continuum of severity. I'll present to you evidence that depicts that this primary aldosteronism syndrome is very common. It has a very high prevalence and it's mostly unrecognized. I'll underscore for you why the current way we approach primary aldosteronism diagnosis is not ideal and how a physiologic or more empiric approach might be better. And finally, I'll show you data that suggests primary aldosteronism is likely a major contributor to the pathogenesis of what is typically considered idiopathic or essential hypertension. So to begin, let's first review what is primary aldosteronism. And I like to start here because there are many flavors of hyperaldosteronism. In other words, not all hyperaldosteronism is the same. Actually, the most common forms of hyperaldosteronism are physiologic forms. For example, the renin-dependent aldosteronism that occurs when we're volume depleted. This is a physiologic form of hyperaldosteronism. When we're volume depleted, the kidneys are hypoperfused. The juxtaglomerular cells sense this and secrete renin, which eventually generates angiotensin II. And as much as this lecture is going to focus on aldosterone, it's important to recognize that angiotensin II is a critical peptide. It is a vasoconstrictor that will help maintain blood pressure when we're volume depleted, but it's also a hormone that helps counter the hypovolemia. So how does it do that? This is a cartoon of the glomerulus and the nephron. The vast majority of sodium and water reabsorption occurs in the proximal nephron under regulation by angiotensin II. And this process is so efficient that very little sodium is delivered to the distal tubule, but we need to extract and reabsorb this remaining sodium to maintain volume homeostasis. And to do that, angiotensin II recruits aldosterone from the zona glomerulosa cells. Aldosterone interacts with the mineralocorticoid receptor in the principal cell to induce ENaC-mediated sodium reabsorption. In this aspect of the nephron, sodium reabsorption will also be paired with water reabsorption, and for every sodium cation that is reabsorbed, one cation must be excreted, either a potassium or hydrogen ion. Now, we do not want to become hypokalemic in an effort to reabsorb volume, and this process is largely mitigated due to decreased distal sodium delivery by angiotensin II, and as well as some direct mechanisms in the principal and intercalated cells. This process is really, we're going to focus on the kidney, but this process is occurring in other organs as well, in the colon and in the skin and sweat glands. So when we're volume depleted, the effect of aldosterone and ENaC-mediated sodium reabsorption is across multiple organs. So this is a renin-dependent aldosteronism triggered or in response to volume depletion, and it results in maximal or optimal sodium reabsorption and volume expansion such that it decreases distal sodium delivery and minimizes potassium excretion. Another form of hyperaldosteronism is also physiologic. This is a renin-independent aldosterone production triggered by extracellular hyperkalemia. And let's just assume, as I describe this, that we're volume replete. If we're volume replete, the juxtaglomerular cells are not secreting much renin and not much angiotensin II is being generated, which means there's a diminished absorption of sodium in the proximal tubule, and that means more sodium will be delivered to the distal tubule. Potassium, extracellular hyperkalemia, is an independent trigger for aldosterone secretion from the zona glomerulosa cell. Here, aldosterone will interact with the mineralocorticoid receptor in response to this extracellular hyperkalemia to induce ENaC-mediated sodium reabsorption for the purpose of excreting potassium. And this process will occur until the initial hyperkalemia is neutralized. So this is a renin-independent aldosterone production triggered by hyperkalemia that results in maximal potassium excretion, whereas it minimizes sodium reabsorption and volume expansion because you've bypassed the proximal tubule. Why should you become volume expanded when the goal here is to excrete excess potassium? And now both of these physiologic forms of aldosteronism occur all the time in nature. Virtually every terrestrial or land mammal is in a state of chronic volume and sodium depletion and is consuming a diet high in potassium. So these animals are not only seeking water, food, and shelter, they're also craving salt. And you can see here some moose in North America licking salt off of cars in the winter. Here you can see other animals either licking man-made salt licks or other mineral salt licks. Now, why are they craving salt? There's very little sodium on land, as it turns out. So for example, in 1 kilogram of vegetation, there's only about 2 to 40 milligrams of sodium. That's about half to one Dorito chip. Not a bag of chips, but a single chip. On the other hand, in a kilogram of vegetation, there's about 8 to 20 grams of potassium. In other words, there's about 20 to 50 bananas worth of potassium in a kilogram of vegetation, or 10 to 30 avocados. Okay, so why am I showing you all this animal physiology? Because this is the same physiology that humans evolved to have, but may not be seen in your everyday world. So most industrialized societies of humans have figured out how to satiate their sodium appetite by either flavoring or preserving most foods that you buy in a supermarket or grocery store with sodium. But you can still find human populations, hunter-gatherer tribes throughout the world that live off of a native sodium and potassium diet. And there are several of these in Papua New Guinea and Africa. I'm going to talk about one tribe of people in the Amazon called the Yanomami, just to highlight this because data is available. So the Yanomami are a tribe of hunter-gatherers that live off the land in the Brazilian and Venezuelan rainforest. And as you can see, their 24-hour urinary sodium excretion is extremely low. It's about half a millimole of sodium per day. And that's about 11 milligrams of sodium per day, about half a Dorito chip. On the other hand, the average American normotensive or hypertensive individual in the United States living in an industrialized society consumes about 4 grams of sodium a day. Just as a reference point, most medical societies recommend restricting sodium to 1,500 to 2,300 milligrams, which is still 100 times higher than the Yanomami. On the other hand, the Yanomami consume a much more potassium than the average American. They consume around 8 grams of potassium a day, what was the equivalent of about a kilogram of vegetation, whereas most Americans consume less than half of that. So you might think, what is the renin-angiotensin-aldosterone system doing in the Yanomami or other wild mammals who are volume deplete, sodium deplete, and eating a high amount of potassium? It should be very high. And indeed, it is. Their plasma renin activity in the Yanomami is around 12 to 15 nanograms per milliliter per hour, very high. And their 24-hour urinary aldosterone excretion rate is around 75 micrograms per day, whopping numbers. On the other hand, the average American has a relatively suppressed renin and aldosterone level. We are so volume and sodium expanded, we don't need our renin-angiotensin-aldosterone system that much. So the Yanomami and other land mammals live their entire existence in a state of hyperaldosteronism, but they're not hypertensive. This is a physiologic hyperaldosteronism that's existing mainly to counter hypovolemia, maintain blood pressure, and excrete potassium. In fact, the Yanomami have lower blood pressures than normotensive Americans. It took us many years to figure this out, but nature had figured this out long ago. In fact, the very first ACE inhibitor, captopril, was derived from the venom of a Brazilian pit viper. And you may wonder, why does a Brazilian pit viper have an ACE inhibitor in its venom? Well, if you imagine, most of the small animals, mice, rabbits, other shrews that it feeds on have a revved up renin-angiotensin-aldosterone system as they exist in a sodium deplete potassium rich world where a whiff of an ACE inhibitor would render them hypotensive. Over thousands of years, the same environmental pressures that forced the Yanomami and other terrestrial animals to evolve a hyperactive renin-angiotensin-aldosterone system also led this Brazilian pit viper to develop an efficient killing mechanism that targeted its enemies' hemodynamic vulnerabilities. So what is primary aldosteronism? So now that we've reviewed physiology, we can appreciate how pathophysiologic primary aldosteronism is. So primary aldosteronism is a renin-independent aldosterone production that occurs despite volume expansion, despite extracellular hypokalemia. So the problem here is that one or both adrenal glands are overproducing aldosterone through one or multiple foci. Volume is expanded, and renin and angiotensin II are appropriately suppressed. So here's the cartoon of the nephron again. Since angiotensin II is maximally suppressed, proximal sodium reabsorption is diminished, which means more sodium is delivered to the distal nephron. Here, it is met with this high or excess aldosterone interacting with the mineralocorticoid receptor in the principal cell to induce excess or increased ENaC-mediated sodium reabsorption, which results in increased volume expansion. And all along, each sodium that's being reabsorbed is paired with the excretion of either potassium or hydrogen ion. So this results in a vicious cycle that leads to cardiovascular disease. You have increased distal sodium delivery, which results in increased distal sodium reabsorption, volume expansion, and increases in blood pressure. This results in further increased distal sodium delivery, increased distal sodium reabsorption, volume expansion, increases in glomerular filtration rate, and further distal sodium delivery, all along with a vicious cycle of hypokalemia and alkalosis, depending on the severity of distal sodium delivery. So what is primary aldosteronism? It is an inappropriate, relatively non-suppressible, renin-independent aldosterone production. This results in excessive activation of the mineralocorticoid receptor in the kidney, a vicious cycle of volume expansion that it can increase blood pressure, increase caluresis and acid excretion, and it can increase the risk for cardiovascular disease regardless of blood pressure due to aldosterone interactions with the extrarenal mineralocorticoid receptor in the myocardium, in the heart, in the vascular endothelium, and smooth muscle cells as well. The clinical manifestations of primary aldosteronism reflect the severity and duration of this renin-independent aldosterone production. It's important to note that one need not have resistant hypertension or hypokalemia. Patients with primary aldosteronism may have normal blood pressure, mild blood pressure, or even normal kalemia, because as I just showed you, both blood pressure and potassium are dependent features. They depend on how much sodium is being delivered to the distal nephron at that moment. The hallmark biochemical diagnostics are a suppression of renin, and in the context of this renin suppression, an inappropriate or dysregulated production of aldosterone. So I hope what you can appreciate here is I have not defined primary aldosteronism with any numbers, no diagnostic thresholds. This is a concept, and this concept or foundation should be used to think about primary aldosteronism as we superimpose diagnostic thresholds throughout this talk. So to summarize aldosterone physiology, we are probably designed to exist in a sodium-poor and potassium-rich environment where volume depletion and a high potassium intake stimulate angiotensin II and/or aldosterone to maintain homeostasis. However, most humans live in a pathophysiologic state where any aldosterone production in a sodium-rich and volume-expanded, as well as potassium-poor environment might be toxic to cardiovascular tissues and contribute to disease. So the next topic I'm going to touch on is the variability of aldosterone production. Now, aldosterone is a hormone, and like most hormones, it is not produced in a static, steady manner. It is actually produced variably all throughout the day. It has a diurnal rhythm, and superimposed on this diurnal rhythm are burst-like pulses that occur throughout the day, sometimes separated by minutes to hours. And this is often an underestimated feature of diagnosing primary aldosteronism. To highlight that, here are 50 patients with confirmed primary aldosteronism. Each one of these patients has been screened and undergone confirmatory testing to confirm the diagnosis. And what you're looking at are different aldosterone levels on different days for each patient. Each black dot represents an aldosterone level measured on a different day for each one of these patients. The red dots represent the mean of each aldosterone level for each patient. And what you can appreciate here is that there's substantial variability for each patient. For example, the intra-individual variability for each participant on different days is sometimes as much as 4 to 5-fold. So what does that mean practically? So if you look at these patients with confirmed primary aldosteronism, the coefficient of variation for aldosterone was around 31%. For the aldosterone to renin ratio was 45%. There's substantial intra-individual variability on different days. The range of aldosterone was quite broad. So these patients with primary aldosteronism at times had aldosterone levels as high as 50 nanograms per deciliter and aldosterone to renin ratios in the several hundreds. So these are subjectively very high, and anyone would agree that those are high. However, they also had aldosterone levels as low as 5 nanograms per deciliter and aldosterone to renin ratios as low as 8. Most individuals would consider that to be low levels. And that's because the number of participants with confirmed primary aldosteronism who had at least one aldosterone level less than 15 nanograms per deciliter was about half. And about a third of these patients with primary aldosteronism had at least one aldosterone level less than 10 nanograms per deciliter. Similarly, a little more than half of these patients with primary aldosteronism had at least one aldosterone to renin ratio less than 20, and about a quarter had one less than 20. In other words, if these numbers or these diagnostic thresholds are meaningful for you, or you use them to include or exclude the possibility of the diagnosis, you can see how much of the subset of these confirmed cases you might have missed on any given day. So, aldosterone production in primary aldosteronism is variable, it's pulsatile. Commonly used diagnostic thresholds are arbitrary. We made them up. And if you use them strictly, it can contribute to false negative case detection, erroneously missing real cases of primary aldosteronism because you strictly followed these diagnostic thresholds. A single cross-sectional circulating aldosterone level is not a reliable indicator of integrated physiology. It clearly doesn't tell you what's happening throughout the day. Now, a single high level might be informative, but a single low level may not exclude the possibility of the diagnosis. And what this means is we have to recalibrate the way we think about diagnostic thresholds as rigid barriers or dynamic guidelines. So the next topic that stems directly from the variability topic is how common is primary aldosteronism? Now, this is a tricky topic because there is no international consensus on the definition of primary aldosteronism. There isn't a strict diagnostic gold standard for primary aldosteronism, which means that throughout the world, even within a country or within a clinic, there's variability on how clinicians define and diagnose primary aldosteronism. For example, one might use the aldosterone to renin ratio, but once you use it, you have to apply an arbitrary diagnostic threshold, 30, 25, 20, etc. You might want to be convinced that there's hyperaldosteronism, and therefore you look at the aldosterone level, but then you have to apply some sort of arbitrary threshold to determine if it's high or low, 20, 15, 10 nanograms per deciliter, etc. Beyond screening tests, you might use a dynamic confirmatory test, an aldosterone suppression test. However, there are multiple different aldosterone suppression tests used throughout the world, and each has its arbitrary thresholds of positivity or negativity. So if your philosophy is to use more liberal or permissive diagnostic thresholds, you'll detect more cases of primary aldosteronism. You'll detect more of a prevalence, but it may come at the expense of more false positives. On the other hand, if you philosophically tend to use more conservative or strict diagnostic thresholds, you'll detect fewer cases. You'll report a lower prevalence, but it's going to come at a higher rate of false negatives, more missed cases. So what should we do about this? So for a moment, let's put aside arbitrary or conventional diagnostic thresholds. Let's ask ourselves, how common is inappropriate, non-suppressible, renin-independent aldosterone production? That is, the fundamental concept of primary aldosteronism. How common is it? And we can do this by trying to turn aldosterone off. Let's do an aldosterone suppression test to turn aldosterone, renin, and angiotensin II off, and then quantify the spectrum of primary aldosteronism, regardless of conventional thresholds. There are many studies that have done this. I'm just going to share with you one recent one that we did. So in this study, we looked at participants throughout the United States, and all of them conducted an oral sodium suppression test as a, quote, gold standard diagnostic. In other words, they consumed a high dietary sodium intake for several days, such that they were volume expanded. Their renin and angiotensin II should have been maximally suppressed. And in the context of a suppressed renin and angiotensin II, you would expect maximum suppression of aldosterone. And the degree of that lack of aldosterone susceptibility reflects some spectrum of primary aldosteronism. And we included participants who were normal blood pressure, who had high blood pressure, and who even had resistant hypertension. So in other words, the participants who completed this oral sodium suppression test represented the entire spectrum of human hypertension. So what did we see? Here on the y-axis, you're looking at the 24-hour urinary aldosterone excretion rate during an oral sodium suppression test among only the participants who had renin suppression and angiotensin II suppression in a volume expanded, sodium expanded state. So what you should see here, or what you expect to see, is a maximum suppression of aldosterone. Instead, this is what you see. This is the data, the raw data for individuals who had normal blood pressure ordered from lowest to highest. And what you see is that many of these patients with normal blood pressure had very solid suppression of aldosterone, as you would expect. Some suppressed less, some barely suppressed, and some absolutely could not suppress. In other words, what you're looking at is a severity spectrum of non-suppressible renin-independent aldosterone production. In other words, primary aldosteronism. These are different shades of primary aldosteronism. And you see the same pattern in stage 1 hypertension, in stage 2 hypertension, and in resistant hypertension, with the difference being that the severity or magnitude of the renin-independent aldosterone production is paralleling the magnitude of the blood pressure phenotype. Now I'm showing you this raw data so you can appreciate that there is a continuum of primary aldosteronism that parallels the continuum of blood pressure. We have not superimposed any diagnostic criteria here, but you can. For decades, the arbitrary diagnostic threshold for primary aldosteronism on an oral sodium suppression test is 12 micrograms per 24 hours. This line means that above this line, you have overt primary aldosteronism, and it also implies that below this line, you somehow don't have primary aldosteronism. And I hope you can appreciate by looking at the raw data and this superimposition of this diagnostic threshold, how limited these binary categorical definitions are. Because clearly, not only do the individuals above this line have primary aldosteronism, but so do those below. They just have a milder form of renin-independent aldosterone production. They should not have their diagnosis excluded. So what I hope to show you here is that prevalence is somewhat arbitrary. You can manipulate prevalence statistics by simply changing the arbitrary threshold for primary aldosteronism, which doesn't really have a biologic basis. But for a moment, let's just use the accepted convention of 12 micrograms per 24 hours. How common is non-suppressible renin-independent aldosterone production or primary aldosteronism? The answer is very. The crude prevalence is 9% in normotension, 15 to 20% in hypertension, and up to a quarter in resistant hypertension. If you ask among those individuals who already had a suppressed renin, how common is primary aldosteronism? There, the prevalence is even more enriched, with up to 50% of patients with resistant hypertension who have a suppressed renin having overt primary aldosteronism. Now, had we used an aldosterone to renin ratio to screen for these individuals, we would have only detected a small fragment of them. For example, the sensitivity of an aldosterone to renin ratio of 30 in resistant hypertension is only 26%. The negative predictive value is only 80%. So in resistant hypertension, where the pretest probability for primary aldosteronism should be very high, the aldosterone to renin ratio is neither good for ruling in or ruling out the diagnosis. And one of the main reasons for that harkens back to the previous principle of aldosterone variability. In patients with bona fide primary aldosteronism and resistant hypertension, on the day of testing, at the moment of testing, a quarter of these patients had an aldosterone level less than 10 nanograms per deciliter. So this just reinforces that aldosterone production is pulsatile, it's variable. A single aldosterone level less than 10 nanograms per deciliter is not necessarily low or inconsequential. It can still be inappropriate, and it doesn't reflect integrated physiology. Another way to show this is from the Pathway 2 study. So the Pathway 2 study was a study where investigators asked, what is the best fourth-line medication for resistant hypertension? In other words, among patients with resistant hypertension who are on a diuretic, who are on an ACE inhibitor, angiotensin receptor blocker, and calcium channel blocker, who still needed blood pressure control, what was the next best medication? And so what they first did was they excluded secondary hypertension among patients with resistant hypertension. In other words, a hypertension expert measured a renin and aldosterone and deemed it to be not consistent with primary aldosteronism. They excluded the possibility, and then participants were enrolled in the study and randomized and crossed over to spironolactone, to doxazosin, placebo, and bisoprolol. And the outcome of the study was that the best fourth-line medication was a mineralocorticoid receptor antagonist, and in a separate aspect of the study as well, an ENaC inhibitor, amiloride. Spironolactone lowered blood pressure much more than the alpha blocker doxazosin, than the beta blocker bisoprolol, and placebo. But where did spironolactone work best? So what you're looking at here is the drop in blood pressure with spironolactone in patients with resistant hypertension as a function of the log axis of renin, log axis of aldosterone, and the aldosterone to renin ratio. And what you see is that spironolactone worked strikingly. It worked best. 15, 20, 25 millimeters per mercury reductions in blood pressure when renin was suppressed, when aldosterone was highest, and when the aldosterone to renin ratio was highest. In other words, it worked best when you had renin independent aldosterone production. But recall, none of these patients were thought to have primary aldosteronism. In fact, their aldosterone and or aldosterone renin ratio were thought to not be high enough to raise concern for primary aldosteronism. But this is primary aldosteronism. A substantial proportion of patients who were thought to have idiopathic resistant hypertension actually had a biochemical form of renin independent aldosterone production that also responded not only preferentially, but proportionately to mineralocorticoid receptor antagonists and ENaC inhibitors. But none of these were deemed to be primary aldosteronism because our current diagnostic radars misclassifying these cases as primary aldosteronism. So the prevalence of classical and overt primary aldosteronism is high, and it's mostly unrecognized. Beyond this arbitrary or categorical definition of overt primary aldosteronism, there is a continuum of renin-independent aldosterone production, what I refer to as a severity spectrum of primary aldosteronism that ranges from mild to severe. And this entire spectrum exists below the arbitrary diagnostic thresholds that we commonly use, and is so also mostly unrecognized. So the key question is, why should you care? Why should we care about this? Is it clinically relevant? Does this continuum of renin-independent aldosterone production play an important role in the pathogenesis and or progression of hypertension and cardiovascular disease? And so I'll show you data that suggests that the answer to that question is yes. Here's data from longitudinal cohort studies. So these are studies that followed a group of people over time to look at predictors of incident hypertension and or cardiovascular disease. The first of these studies was published in the New England Journal of Medicine over 15 years ago. These are patients from the Framingham Heart Study who had normal blood pressure and all had their aldosterone levels measured. And what these Framingham investigators observed was that the higher the aldosterone level among patients with normal blood pressure, the greater the risk for incident increases in blood pressure and the development of categorical hypertension. But it wasn't just that they had higher aldosterone levels, it's that the patients who developed the greatest increases in blood pressure and the greatest conversion to hypertension had the lowest renin levels and the highest aldosterone levels in the context of the low renin. In other words, if you're a normotensive individual and you have a biochemical phenotype of renin-independent aldosterone production, your risk for developing increases in blood pressure and high blood pressure in the future is much higher. Here's a separate study we conducted in a different cohort, in the MESA cohort, multi-ethnic study of atherosclerosis, that showed very similar findings. In the MESA cohort, among individuals with normal blood pressure, just having a low renin, a suppressed renin activity, was an independent risk factor for developing incident hypertension. So now I'm going to superimpose aldosterone levels on these renin levels. So here on the left, you're looking at normotensive individuals who have a suppressed renin phenotype. And what you see is the higher the aldosterone concentration in the context of this renin suppression, the higher the risk of developing incident hypertension. And you can see here, these are normotensive individuals who have undetectable renin activity and aldosterone levels of 12, 15, 20, 25 nanograms per deciliter. They look like they have primary aldosteronism, and that biochemical phenotype parallels increased risk. On the other hand, if you were a normotensive individual, but your renin was not suppressed, you still developed hypertension at a background frequency. It just was not associated with aldosterone levels. There are other causes of hypertension. If you were a hypertensive person in the MESA cohort, having a biochemical phenotype of renin-independent aldosterone production increased the risk of coronary artery calcification and death, in part due to increases in blood pressure and worsening of hypertension, but also an independent and possibly direct effect. So the magnitude of this biochemical phenotype of renin-independent aldosterone production, in other words, primary aldosteronism, is clinically relevant. As I just showed you, in patients with normal blood pressure, it increases the risk for incident hypertension. The magnitude of the renin-independent aldosterone phenotype in patients with high blood pressure increases the risk for cardiovascular disease and death. And the reason this is so important is we've known now in studies ranging over 50 years, clinical trials and intervention studies, that mineralocorticoid receptor antagonists, and ENaC inhibitors in patients with a low renin phenotype, and particularly those with low renin and higher aldosterone levels, results in striking reductions in blood pressure. So we refer to this as the severity spectrum of primary aldosteronism. In the context of renin suppression, higher aldosterone concentrations are associated with an increased risk for developing increases in blood pressure, incident hypertension, and cardiovascular disease. And the magnitude of this biochemical phenotype predicts the magnitude of the response to mineralocorticoid receptor antagonists and ENaC inhibitors in terms of blood pressure reductions. And you can see this severity spectrum in normotensives, in patients with high blood pressure, all the way to resistant hypertension. In the words of John Funder, who chairs the primary aldosteronism guidelines, we need to start recognizing that the true prevalence of primary aldosteronism needs to include dysregulated or inappropriate aldosterone production. In other words, the strict definition of primary aldosteronism based on arbitrary and classical diagnostic thresholds no longer works. It's missing most of the diagnoses. Much of the present guidelines need to be jettisoned, and radically reconstructed recommendations should be developed. So this is how I think about primary aldosteronism. This is the severity spectrum of primary aldosteronism, ranging from low in blue all the way to high in red, and it's paralleled by the risk for cardiovascular disease. This gray line represents the current indications to screen for primary aldosteronism, meaning individuals with resistant hypertension and or hypokalemia. And if you restrict screening to only these individuals with an aldosterone to renin ratio, you will only detect overt or classical primary aldosteronism, an obvious syndrome of mineralocorticoid receptor excess that results in hypertension and hypokalemia. But as I showed you, if you move to the left of this line and conduct aldosterone suppression tests, regardless of these screening indications, you will find that many individuals with high blood pressure and even those with normal blood pressure have overt primary aldosteronism, that is, overt non-suppressible renin-independent aldosterone production. And this is almost all unrecognized because we don't screen most of these individuals. And more importantly, even to the left of this line, there is a clinically relevant spectrum of renin-independent aldosterone production that is relatively non-suppressible, that extends across the entire blood pressure continuum. And we've referred to this as a continuum of subclinical or non-classical primary aldosteronism, but in reality, to avoid semantics, it is just a milder shade of primary aldosteronism that goes from mild to severe. Now, the reason this is important is because if you use categorical definitions, you will find very high prevalence estimates in resistant hypertension and hypertension. But as I showed you, these are modifiable prevalence estimates depending on your philosophy. What's more important to take away from this is that the spectrum of renin-independent aldosterone production ranges across blood pressure phenotypes, and it's paralleled by responses in with two mineralocorticoid receptor antagonists and ENaC inhibitors. Another sobering statistic is that currently less than 3% of patients who have resistant hypertension and hypokalemia are ever even being screened for the diagnosis. So that represents a huge problem. On one hand, we're showing you this huge severity spectrum of primary aldosteronism, and on the other hand, very few clinicians are even looking for the disease in the most severe state. So I will finish by discussing implications for diagnosis. So what do all of these changes in the way we think about primary aldosteronism mean for how we should approach diagnosis? So I think when we think about the diagnostic approach for primary aldosteronism, it's philosophic. There is multiple ways, multiple right ways to make the diagnosis, and it doesn't really matter how you do it as long as you do it more often and more judiciously. So I'm going to present to you two philosophies just to show you the different approaches that many individuals across the world take. Philosophy one towards diagnosis is what I refer to as the purist philosophy. The purist clinician wants to eliminate all potential confounders of renin and aldosterone. So they want to eliminate factors that might raise renin, lower aldosterone, and or lower the aldosterone to renin ratio. That means in this philosophy, you want to withdraw all potential confounding medications for several weeks or even a month or more. The main culprits there are mineralocorticoid receptor antagonists and ENaC inhibitors, but also ACE inhibitors, angiotensin receptor blockers, diuretics, beta blockers. So that means you have to stop these medications for several weeks and control the patient's blood pressure with other modalities. The purist will also want to make sure potassium is not confounding aldosterone levels. As we know, low potassium levels can suppress aldosterone, high potassium levels can stimulate it. So you often will have to supplement with potassium, which can be challenging, especially since you've now withdrawn potassium sparing diuretics. Um, to be a purist, you'll probably want to measure the blood work in the morning at the same time of the day to control for time of day and diurnal variation. So the patient will have to come back on a different day. And sometimes you'll even try to control the influence of estrogen, either endogenous or exogenous estrogen levels. So the pros of this approach are that it controls physiologic confounders. And if you do this the same way on each patient each time, you can calibrate and interpret your results using some fixed and reproducible standard that you have created. But there are many downsides. So this is a fairly complex, time intensive, and laborious process, right? It can take several weeks of effort on your part as the clinician and for the patient. Stopping, changing medications, communications regarding blood pressure, repeated blood tests to make sure potassium is adequately controlled, etc. And this can be a major hindrance for patients and for clinicians. Just to reiterate, we do a very poor job of screening for primary aldosteronism. In the United States, less than 3% of patients with resistant hypertension and hypokalemia in major academic medical centers are ever screened for primary aldosteronism. So these are two red flags to screen, and it's not being done. So on one hand, I'm telling you that the prevalence of primary aldosteronism is extremely high. On the other hand, I'm telling you that the awareness, education, and implementation of screening is extremely low. So how do you bridge this gap? I would argue that a complex, laborious, time-intensive screening protocol is probably not going to increase screening thresholds. In medicine, the best screening tests are generally simple and easy to implement. So with that, let me show you an alternative approach. And I'll just say, if this philosophy of withdrawing potential confounders is something that you and your patient can reliably do, go for it. If it works for you, that's great. But if this is too complicated for you or very laborious, you can consider a more pragmatic approach, philosophy two, which I refer to as don't hesitate, recalibrate. And to be completely honest and in full disclosure, this is the philosophy that I would argue needs to be performed much more commonly and one that I usually try to do if possible. So in this philosophical approach, you would measure renin and aldosterone at any time on any medication. In other words, if you even suspect primary aldosteronism, don't miss the opportunity to screen, don't hesitate, measure right then and there, and then you'll recalibrate how you interpret the results. Because if the renin is suppressed, your results are likely interpretable. What you're looking for a positive screen is evidence that your patient has renin-independent aldosterone production. So step one, they need a suppressed renin. With a plasma renin activity, this is ideally less than 0.6 nanograms per milliliter per hour. With a renin concentration, ideally less than 5 milliunits per liter, but you can use more liberal criteria if you want to increase your sensitivity. Once you've confirmed that renin is suppressed, you want evidence that there's inappropriate aldosterone production relative to this renin. And again, this is philosophical. If you use higher diagnostic thresholds, the cases that you diagnose will more likely have primary aldosteronism, but it will come at the expense of more missed cases. You'll miss milder to moderate cases. If you use lower diagnostic thresholds, you will diagnose more cases of primary aldosteronism, but it will come at the expense of more false positives. Using this pragmatic philosophy, what is a negative or uninterpretable or confounded screen? It's one where the renin is not suppressed when you had a high pretest probability or the aldosterone level is not high enough. And on a case-by-case basis, when you end up in this scenario, you can consider a washout or removal of confounders to increase the likelihood that you'll be able to include or exclude the diagnosis with confidence. So the pros of this approach is that it's easier and quicker. You've decreased barriers to screening and hopefully more opportunities to screen individuals and make the diagnosis. And it usually doesn't require as many changes to medications and back and forth with the patient. The downside is you have to recalibrate the interpretations for the specific patient in front of you. In other words, you have to think a little bit more and try to interpret for you and your patient, is this inappropriate, renin independent, and non-suppressible aldosterone production? So my general advice for screening, don't delay, don't hesitate. If you even suspect primary aldosteronism, go ahead, measure a renin and aldosterone right then and there in the clinic. If the renin is suppressed, you can interpret the results and make useful decisions. I often say you should consider yourself to be the final frontier. If you don't make this diagnosis, it might never be made, and this patient may never get diagnosis, which is a shame. So to maximize sensitivity, you should use the lowest threshold possible for defining inappropriate aldosterone production in the context of renin suppression and a high pretest probability, such as a patient with hypertension. As I mentioned, washing out and changing medications is a laborious and time-intensive process, and usually it's not necessary. Now, if you suspect primary aldosteronism and the renin is not suppressed or the aldosterone level is not high enough, on a case-by-case basis, you can consider a medication washout to minimize confounding. And the main culprit here are mineralocorticoid receptor blockers and ENaC inhibitors, medications that raise renin, lower the aldosterone to renin ratio, and might result in a false negative. You should stop those for 2 to 6 weeks and then repeat testing. It's true that ACE inhibitors, angiotensin receptor blockers, and diuretics can sometimes contribute to confounding, but in my opinion, rarely is a washout needed for these other medications, and you can consider them on a case-by-case basis when you strongly suspect the diagnosis, but you do not get diagnostic results for renin and the aldosterone to renin ratio. So let me put this all together for you in a final algorithm. What are the indications to screen for primary aldosteronism? The at minimum essential indications are severe or resistant hypertension and any hypokalemia, regardless of blood pressure, regardless of why the hypokalemia occurs, diuretic or non-diuretic induced. Further, anybody who has hypertension and an adrenal mass or hypertension and sleep apnea or a suggestive family history for inheritable forms of primary aldosteronism should be screened. The screening tests are to measure a renin and an aldosterone right then and there without delay. Once you get the renin and aldosterone, the real work is on interpretation. So what you want to be convinced of is that there is renin-independent aldosterone production. So step one is the renin suppressed. If the renin is suppressed and the aldosterone is greater than 15 nanograms per deciliter, this should be considered an overtly positive screen. There's very few things that this could be other than primary aldosteronism in the right pretest probability. Certainly with any evidence of hypokalemia, you've made the diagnosis of overt primary aldosteronism. If you'd like, I generally recommend repeating a renin and aldosterone on a separate day in the small chance that this is a false positive. This is the easiest way to make the diagnosis. I call this the simplified confirmatory pathway because it just requires phlebotomy, a venipuncture for renin and aldosterone. If the renin is suppressed and the aldosterone is less than 5 nanograms per deciliter, very low subjectively and by almost every standard, this is likely a negative screen and you've excluded the diagnosis of primary aldosteronism. To be certain, you can repeat the renin and aldosterone on a separate date in the small chance that this was a false negative. Another way to exclude the diagnosis is if the renin is not suppressed. You can't have renin-independent aldosterone production if the renin is not suppressed. The caveat being, if the patient is on a medication known to raise renin, the biggest culprits of which are mineralocorticoid receptor antagonists and ENaC inhibitors, you should withdraw these confounding agents and repeat screening on a separate day. This is the easiest way to exclude the possibility of primary aldosteronism, what I call the simplified exclusionary pathway. So that leaves us with a suppressed renin and an aldosterone level that's neither very low nor very high. It's between 5 and 15 nanograms per deciliter. And I would encourage you to call this a positive screen to maximize the sensitivity for making the diagnosis and minimize the likelihood that you miss true cases. Here, extra work needs to be done. So I call this the enhanced diagnostic pathway. If your patient is not willing or able to undergo more advanced testing, you should empirically treat this patient with a mineralocorticoid receptor antagonist therapy. At minimum, this patient has low renin hypertension and has a very high likelihood of having some form of primary aldosteronism. In other words, they're very likely to have a solid blood pressure response to a mineralocorticoid receptor antagonist. If they are willing to undergo further testing, an aldosterone suppression test can be conducted, and depending on what you're familiar with and what you feel comfortable with, this could be an oral sodium suppression test, an IV saline suppression test, a fludrocortisone or captopril suppression test. They're all very useful. If there's marked suppression in aldosterone, you've excluded the possibility of the diagnosis. But if there's clear failure of suppression using conventional thresholds or even marginal suppression relative to those thresholds, you've likely made the diagnosis of mild to severe primary aldosteronism that is very likely to respond to targeted therapy, and then you can pursue localization, and treatment processes. So to summarize this talk, we reviewed that the distinction between overt primary aldosteronism as a categorical distinction and relatively non-suppressible renin-aldosterone production as a continuous distinction is an arbitrary construct, and it's limited to identifying the most severe instances of primary aldosteronism. We reviewed that primary aldosteronism is a highly prevalent syndrome of renin-independent aldosterone production. It exists across the entire spectrum of human blood pressure and can manifest across a range of severity, but most of that range is below our current diagnostic radars and thresholds. We're not looking for it or recognizing it. There's a large intra-individual variability in aldosterone production, not only diurnal, but burst-like pulsatility throughout the day, such that a single circulating aldosterone level and the aldosterone to renin ratio are not always reliable surrogates of integrated physiology. Certainly, if they're very high in the right pretest probability, they can be informative, but low levels may not be exclusionary. On the other hand, a suppressed renin is a very good biomarker for a phenotype that's enriched for primary aldosteronism and responds preferentially to a mineralocorticoid receptor antagonist and an ENaC inhibitor. Almost any aldosterone in the context of a suppressed renin and the right pretest probability could represent a form of primary aldosteronism that responds well to this type of targeted therapy. And finally, we reviewed that the magnitude of this renin-independent aldosterone production is consistently associated with the severity of blood pressure, worsening blood pressure, and proportionally with the increased risk of increased likelihood of responding to mineralocorticoid receptor antagonists and ENaC inhibitors. In other words, the magnitude of the renin-independent aldosterone production is clinically relevant. It's associated with incident cardiovascular disease risk, and it responds in parallel to targeted therapy. So with that, I conclude the lecture on the expanding spectrum of primary aldosteronism.